So coming to the podium is Dr. Jay Pershad, one of our emergency department faculty and practitioners, and he is going to bring everyone up to speed on actually things we can do in our practice. Jay.
Yeah.
You can stay here. You're going to.
Yeah. Good morning. Yeah.
Can you
Delight to be here. Can you hear me? So my goal today really is to empower you. And thank you, Mark. Is to really empower you to expand your repertoire of procedures that you are probably already doing in your office. And then the other thing is to share with you some strategies for success based on three things. One is proper case selection. The second is having the right tools. And the third is share some tips to do it right with the right technique. So if you think about it for a minute, we're going to go over a few things. We're going to go over retrieving foreign bodies from the ear and nose. We'll also look at some minor orthopedic injuries that you can actually immobilize in the office, and you may not even need to refer them to the orthopedist if you're comfortable following up with them. So they don't need urgent referrals. And then we'll talk about some simple procedures like IND of an abscess or treating minor wounds in the office. And then finally, we'll talk about the importance of having a toolkit. So if you think about it, the value proposition, it can really be a win-win for everybody. Win-win for the patients and the family. It can also be a win-win for the practice, as Dr. Kresley said. Like it or not, the RVU and the CPT system favors procedures. And I'll share with you throughout the conversation we're having today that there are some serious disparities. If you can do some procedures, you can generate some RVUs and some revenue. And then, of course, it's the professional satisfaction piece. So if some of you like doing procedures or want to expand your repertoire, this might be an opportunity to learn and master that technique. And then finally, it's the avoidable referrals that, some insurance companies I know are looking at things like number of patients sent to the emergency department or the urgent care centers and things like that. So let's look at the foreign body removal piece. So I'm going to start with the foreign body in the nose. Common problem. And my go-to is actually a balloon extractor. Have you got it in your office? Have any of y'all got one of these balloon tips? So I can see some hands going up. I brought my little toolbox with me, but it's really very, very, very simple. It's you maneuver this catheter into the nose behind the foreign body, and then you inflate this balloon at the tip. And you probably can't see it, but you're welcome to catch me afterwards. And then you just pull and you can get the foreign body out. It's very, very easy. If you can get the child to cooperate, which sometimes is a challenge. But we'll talk about that. I think we'll talk about that a little bit. But you know the families well, and you know the children well. And I think if you can engage the parents, I think you can certainly do it. Other ways you can do it is, and that's the balloon catheter I was telling you about. There's a parent kiss technique. I think if you get a call, I've got a bead in the nose. If the family is comfortable, or if they're in the office with you, you have the parent blow into the nose and you occlude the other nostril. So basically the air is going to pop that bead out or pop that foreign body out. And then if you don't want to have a parent who's comfortable, you can also use the bag mask that you have in your little resuscitation kit, if you do. And then the alligator and the bayonet forceps are another good tools to have with you. And here, and I'm not going to dwell too much on the CPT piece, but the procedure code needs to be submitted with a low-level E&M code. And then those are the RVUs that you can capture for. And I just put, for example, a new patient office visit 99202 is 2.16. And believe it or not, a foreign body in the nose can get you a few more RVUs now. So the balloon tip extractor that we talked about. Let's look at this one, the ear foreign body. This can be tricky. I know I was working in our urgent care center the other day, and the stub of an earring was pushed into this 5-year-old's ear. And I did some things wrong. I got frustrated, tried a couple of times. The child didn't tolerate it, ultimately had to refer them to ENT. Just wasn't a great experience for the family, not a great experience for the child, and so on and so forth. So I know, this can get very frustrating. And that's where I want to talk a little bit about case selection and the type of foreign body. So the go-to technique, if they've shoved some piece of paper, a little bit of cloth in the ear or something else, or maybe a little bead in the ear, irrigation is a great technique. And you can have different ways you want to irrigate. My style is you take a little stiff 20 gauge angiocath and you flush it, you direct the stream of water posteriorly into the canal. And eventually with a few tries, it's going to pop out. Obviously, you want to avoid irrigation if it's an organic foreign body like vegetable matter, because that's going to make it worse. And then obviously, if there's an obvious perforation or something, then you might want to avoid it. And remember that you want to take a quick look after the procedure is done. And you'll often find a pink tympanic membrane. So it's not otitis. This can occur. But this is one approach that you can take. But irrigation is not very threatening, especially if you have tepid water. If you can get it, it's very comfortable. It's just, I tell the children, it's just like having a shower and there's some water going in the ear. And then the metal ear curette. How many of you have metal ear curettes, like for wax removals and things like that? Great, I see some hands going on. This is a great tool. The plastic ones, when you use for removal of wax, etc., they tend to flex and bend. The metal curette is a great friend, and I didn't have it when I was working last week with that little child I was telling you about. I wish I had it, I didn't. I'd lost it, but I'm definitely going to get one. But you can maneuver that behind and then pull, and you're going to get the foreign body out. And then, of course, the alligator forceps and the days hook. All what a days hook is it's a metal with a right angle hook at the end. You can use it for wax removal. If it's a very hard wax in the ear, you can put this hook and just dislodge it a little bit. But you have other uses of these instruments. And part of the reason the procedure RVUs are higher, especially in the non-facility setting, which is in the office setting, is because they recognize that there may be some investment in the practice expense piece to get some of these instruments. And I just put the earwax removal code that you probably use. If you're not using is something, that's the one that you use, 69209. Again, the alligator and the bayonet forceps. Small alligators, great tool to have. Bayonet is good because it gets the tip of the forceps out of your field of vision. Well, I think I'm going to tear my jacket there, but that's the bayonet, so you can actually, if you have none of these tools, I think maybe just investing in a few of these, believe it or not, I shouldn't be saying this loud, but all of us do it in the emergency department, the urgent care setting. We have a little toolbox of our own. We just wipe it down and reuse it on the next child. They don't need to be trashed. What about minor orthopedic procedures? I think this is an opportunity that is underutilized, if you ask me. Say you have a child who comes to you. Let's look at a 5-year-old, fell in the park, the wrist hurts. Mom and dad are with the child, and you take a look, and the patient's tender over the distal radius. It's not deformed. It's a little bit swollen, maybe. You have an index of suspicion this might be a fracture. You send them for radiology, wherever you send them. If you don't send them to Children's, you send them to a private radiology service. And when you do that, and the radiologist calls you and says that there is a small buccal fracture. So it's a unicortical buccal fracture. You can see that over there. Very well aligned, not displaced. You don't need to send that child to us or to any orthopedist. You can put them in a removable Velcro splint. And there's plenty of data now that these children will heal very well. And you can either follow them up in a couple of weeks, or you can send them later to the orthopedist if you want to have that tight follow-up. Again, procedure codes for fractures. They generate a lot of RVUs. I know a lot of us love this, right? We want it to be nursemates, the 2.5-year-old who comes in playing with their sibling, don't know what happened. They have I like to call it with the residents, pseudo paralysis of that left upper extremity. Essentially what it is it hurts when you move the elbow, but you can't localize the pain. Now, if they've got obvious swelling and they've got obvious bruising at the elbow, that's a fracture. That's not radial head subluxation. But if you're not sure, which is what happens a lot of times, it's okay to try the radial head subluxation maneuver. And if it doesn't work, then you're going to get some x-rays, right? So just one little tip for radial head subluxation procedures. Do people do hyperpronation at all for radial head, for nursemaids? Or do you do supination and traction? Supination. So here's a tip. If you haven't done it, do hyperpronation. It's less painful. So a little bit of axial traction, and then you hyperpronate. Try that first. And if you feel that clunk, and if you feel like you've reduced it, you're done. But try hyperpronation before going to supination. Less painful. There's plenty of data on that. And then now what if they have an occult supracondyle? You send them to the radiologist, and the radiologist says, there's a non-displaced, what looks like a supracondylar fracture because they have a huge fat pad. Fat pad is nothing but effusion or blood in the elbow joint. And that pops up on the x-ray as that little arrow there that you can see behind the humerus. But if they have a non-displaced supracondylar fracture, and if you have the capabilities in your office, you can just put them in a long arm splint. So a 90-degree splint, if you've got some fiberglass with you, 90 degrees in neutral position. And you can send them to the orthopedist the following week, and they'll convert it likely to a circumferential cast. But that's perfectly fine. They don't need manipulation, and they can heal well, but that's appropriate immobilization in the office. Similarly, you have a toddler who's refusing to walk, and you're suspecting a toddler's fracture because they're tender over the tibia. You get an x-ray, and oh yeah, there's a little hairline lucency. And fresh off the PAS meeting in Hawaii, a multi-center randomized trial from the Sick Kids Hospital in Toronto looked at this very carefully. We do this, but this validates our practice. We put them in a removable boot versus putting them in a circumferential cast, and then we have them follow up with our orthopedist. And the removable boot, the pain scores at 4 weeks were not inferior to the casted patients. So again, I think less is more. Now you might say, I don't have a boot. I have trouble getting this boot as well sometimes when I'm working in the off-site areas of Children's National Emergency Department. But if you can get it, this is all it takes. You don't need to do anything. Just come back, mom and dad, to the office. I'll put you in a boot and you're home. Again, here's another one. Fell on the monkey bar, is tender over the clavicle. You see that all the time, right? You send them, get an x-ray, and lo and behold, it's a horrible looking clavicle fracture, right? You look at them and they look, oh my God, that thing is broken. The parents look at it, they freak out. But you know what? I tell the parents, that's the best bone to break because it heals beautifully. No intervention required. If I send them to the orthopedist, they'll laugh at me. They'll say, I'm not going to do anything. Just put them in a sling and send them home. But that's exactly what it needs. We used to do sling and SWAT and all of that for these patients. Just a sling is fine, and they may not even need to go to the orthopedist. You can call them back in 3 weeks. I think the only thing I would tell them is you're going to have exuberant callus. So a week from now, it might look like, oh my God, there's a dramatic swelling there. But that's all it is. But these are fractures that heal beautifully, and something that you can manage in the office very, very well. So here's a quick table. All this is in your handouts, but I also want to draw attention to these little finger fractures. If you have a finger splint, if they're non-displaced, finger fractures can certainly be placed in a finger splint. Similarly, if you have a metatarsal fracture, you can put them in a hard sole shoe. That will also work. Let's move now a little bit to somewhat painful procedures, right? And I saw a slide by our previous presenter, Dr. Leslie, with the buzzy. How many of y'all have buzzies for injection pain from shots? We'll talk about that. I see some hands going up. That's great. Yeah, that's great. How many of you have vapor-coolant sprays? Excellent, excellent. So the cold will numb the, use it for immunization pain. Your parents will love you for it, right? You'll become a practice differentiating. No, just kidding. No, it's not that dramatic. But for IND of simple abscesses, it can be done in the office. If they are small, less than 3 centimeters, we have the luxury in the urgent care setting of the emergency department of using LMX cream, which is 4% liposomal lidocaine. You may not have that. You may not have injectable lidocaine, which I understand completely is a lot to keep in the office. But you know, a little pain ease vapor coolant spray on the top of the abscess, and then just pop it with the number 11 blade, and you drain the pus. And if you are keen on antibiotics, some people say if it's a small abscess that's fully drained, you may not even need to put them on antibiotics. But if you do, if there's SSTI with purulence, Bactrim or doxycycline is a better choice because it covers staph and strep. SSTI without purulence, which is just cellulitis that you're treating, then cefadroxil or cephalexin. I like cefadroxil just because it's a once a day thing you can prescribe. Again, here's your, let's look at wound management a little bit. Can I really fix lacerations in the office? You can, of course you can, because we have a lot of opportunity with tissue adhesives now. But the important thing is case selection. By that I mean is choosing the right type of laceration. So they can be on the scalp, on the face, on the extremities, small ones. They're not deep, where the wound tension is not high. So there's not a lot of wound edge separation. And one of the things I find is the most common laceration that parents might bring the child in for you is the one on the foreheads, right on the eyebrow, forehead, fell while running. They may be deceptive. With the blood clot on there, they may look very superficial, but my only tip to you is just dislodge that little clot and see the depth of the wound. If it looks like it's all the way down to the, down through the muscle, then that may need a 2-layer closure. That may not be amenable to Dermabond. But if it's a superficial laceration, by all means, you can do that. It should be low tension, does not cross the joint, and it's non-contaminated. And you've seen this. There are various flavors. There's histoacryl blue at one of our sites. There's the Dermabond is the commercial name for the cyanoacrylate adhesive. But the key to putting this is a couple of things. One is you got to have the bleeding stop. So make sure they have hemostasis. The other thing you need to do is once they have hemostasis, because otherwise it becomes a gooey mess, you don't need to swipe the entire glue on the lac at one time. You can put a few drops, as it's shown there in the picture. So you can do it piecemeal, it's okay. It stings. How many of you have personally had Dermabond done on a laceration on yourself? It stings, right? If it goes into the subcutaneous tissue, it stings a lot. And you're going to lose the trust of the child. They're going to scream because it hurts so much. But that's the main thing, is you want to have the wound edges approximated, have extra help if you have in the office, and then put the glue on it once you've achieved hemostasis. Works really well. Scalp lacerations. Very well described technique of hair apposition. So we just had a talk on alopecia. So if you're alopecic, you can't. If you have a lot of hair, you can certainly, you can tie the hair and pull the lac together and just put a drop of tissue glue on it, and you're done. You're done. Scalp's not a big, great cosmetic area. But it really works. This really works, especially the studies came out of the Asian, like Taiwanese was the original study where they have long hair. You know, it's very easy. I suppose if you have curly hair, it's going to be very difficult. And then staples. If you haven't seen staples, it's another opportunity. You know, I think you can, scalp lacerations, we use a lot of stapling on the scalp. It's easy, but you need to numb it a little bit, which you may not have the opportunity. But if we staple it, we give the parents a staple remover or ask them to come back and take it out. So distraction techniques, you can use it for your immunization pain. We talked a little bit about Buzzy. Buzzy, all it is it's a vibratory tool. You turn it on, put it on the skin, and the vibration, what it does is activates those nociceptive pathways and uses can't remember from medical school, is it gateway theory or some theory like that? Anyway, you're reducing the pain of the intervention that's going to happen, and it works immediately. The other option is puppet toys. Have you seen these? These are, a lot of our teenagers and children like to pop it, and it's a distraction technique, but I suggest you try these, especially if you're attempting one of these procedures that might be painful. And then we talked about tools for success. I think a trip to the local hardware store is a great idea. One of the tools that I really love is the headlamp. Because once I put the headlamp on, I can look at the foreign body in the nose, in the ear, at the laceration. It frees both my hands up. Another great tool, and those are the ones we talked about. We talked about the metal curette, we talked about the bayonet forceps, we talked about the small alligators. But one of the other things, if you're interested, is my mentor used to carry the pointers with the magnet on them. So if you have a magnet that some child stuck up their nose or ear, great tool to pull it out. And then another one, and this is completely digressing, is you may not have this option, but if you don't have a papoose board, what I would suggest is take a sheet, wrap them up. I mean, hey, we call it a burrito roll in our parlance, but but you need, if the child's going to reach up when you're trying to get that foreign body, I think you need some sort of restraint. That's my suggestion. We have those Velcro wraps. And then finally, this is totally offbeat, but have you had one of these LED lights? Great tool for taking throat swabs and things like that. I don't know if you've ever, I was just thinking, I can hold the head of the child, I can use a tongue depressor, I've got the light on it, I can take a throat swab. So little things, a trip to the hardware store can get you a lot of bang for the buck. And then before we go to the takeaways, I want to quote Dr. Kressley, and I love what she says. She says, the kids sent me here, the kids sent you here. Great opportunity for us to collaborate and learn so we can really improve primary care for the children in our communities. Thank you for supporting Future of Pediatrics. Thank you for all your referrals to children's. My takeaways are 3, like we talked about. Think about the value proposition. It can be a practice differentiator for you. If you can treat that minor fracture, get that foreign body out, maybe a small lac, I can take care of it for you, mom. Think about proper case selection. If it's a big abscess, if the foreign body in the ear is sitting right near the tympanic membrane, maybe not a good idea. And then finally, have a toolbox in the office. It's hard when you're doing a procedure and you're scrambling to get stuff together. I brought some of these tools in a little plastic bag. Thank you for your attention.